Hello everyone. In today's session, we are going to discuss about typhoid fever. It is a continuation to the topic epidemiology of communicable diseases in a preventive and social medicine. The objectives of this session are the introduction to typhoid fever, the problem statement, epidemiological determinants, that is, agent factor, host factor, and environmental factors. The environmental and social factors, incubation period of typhoid fever, what are the variable modes of transmission of the fever, what is the pathophysiology behind the typhoid fever in the patient, and what clinical features, that is the signs and symptoms the patient presents with. How do we diagnose it as typhoid fever, and what are the investigations which have to be done, the complications which can arise due to typhoid fever, and how we can prevent the typhoid fever in patients or in the healthy person. How can we prevent the occurrence of the typhoid fever? In the patient, we can prevent the progression of the fever. Now, let us start with the introduction. The term enteric fever includes typhoid fever. Enteric fever includes typhoid fever. It is caused by Salmonella typhi. Okay? Here you can see what is the causative organism. The causative organism here is Salmonella typhi. The French physician Pierre Charles and Alexandre Louis, Pierre Charles Alexandre Louis, he was the one who first proposed the name typhoid fever. He gave the name typhoid fever. You can see the picture of Pierre Charles Alexandre Louis. Carl Joseph Ebert was the one who discovered the typhoid bacillus in the year 1880. The name, you saw, the name was given by Pierre Charles Alexandre Louis, and the bacillus was discovered in 1880 by Carl Joseph Ebert. Then comes George Vidal, who discovered the Vidal agglutination reaction of the blood. So he described the agglutination reaction. The Vidal test is performed. In that Vidal agglutination reaction of the blood was described by George Vidal. Typhoid fever is a result of systemic infection mainly by Salmonella typhi. So here we are starting the introduction of the typhoid fever. We see that it is a systemic infection. So variable organs are involved in this fever. So the Salmonella typhi causes the typhoid fever, and it causes the systemic infection. It is found only in man. So you do not see the typhoid fever in other herds. You see that it is seen in man. The disease is clinically characterized by a typical continuous fever for 3 to 4 weeks. Here, when the patient comes to you and tells that the fever is there since 2 weeks, 3 weeks, and up to 4 weeks, one of the diagnoses which you can think of when it is fever and the fever lasting for 3 to 4 weeks or longer, we should think of typhoid fever. Relatively, there will be bradycardia and the involvement of the lymphoid tissues, and there are considerable constitutional symptoms which we will discuss in the clinical features. So the patient presents with the constitutional clinical symptoms and then bradycardia and fever up to 3 to 4 weeks. Is it clear? What are the clinical features? Fever, bradycardia, involvement of lymphoid tissues, and other constitutional symptoms. The term enteric fever is including both the typhoid fever and paratyphoid fever. Is it clear? enteric word is including the both the typhoid and paratyphoid fever. The disease may occur sporadically, epidemically, or endemically. See, it can occur endemic locally, sporadically, or epidemically as well. Moving further to the problem statement. World Health Organization estimated the global typhoid fever disease burden at 11 to 20 million cases annually. So you see in the problem statement we discovered that there are 11 to 20 million cases of the typhoid occurring globally, and then this is resulting in an estimated 1,28,000 to 1,61,000 deaths per year. So, something ranging around 1,28,000 to 1,61,000. Okay, 1 lakh you can remember, 28 to 61,000 cases per year, deaths per year. Cases are 11 to 20 million cases, whereas the deaths are 1,28,000 to 1,61,000. And these deaths are predominantly recorded in the children of the school age group or younger. Majority of this burden occurs in Asia. So you can see the majority of the burden of the typhoid cases and deaths are occurring in Asia. Typhoid fever is endemic in India. Reported data for this year 2018 shows that 2.30 million cases and it has recorded 399 deaths in India. In the year 2018, there are 399 cases. Maximum cases were reported from Uttar Pradesh, 7,64,272 cases, and 224 deaths were from Uttar Pradesh. So, from the overall country, India, we see that the number of cases are 399, whereas from Uttar Pradesh itself it has recorded 224, highest number of cases, with the cases 7,64,272. Followed by the Uttar Pradesh, we have West Bengal in Karnataka, which has recorded 1,27,150 cases and no death. Okay, this is West Bengal and Karnataka. Okay, followed by we have West Bengal, then Karnataka, which has recorded almost 1,27,150 cases, whereas there are no deaths recorded. Moving further to the epidemiological determinants. So it is the triad of agent factor, host factor, and environmental factor. So let us begin with the agent factor. Salmonella typhi, S. typhi, is a major cause of enteric fever, and there is also Salmonella paratyphi that usually causes a less severe illness. We see we have Salmonella typhi which causes more severe infection, okay, and the Salmonella paratyphi causes less severe, SS, okay. Salmonella typhi causes severe, paratyphi less severe. Salmonella typhi has three main antigens. The three main antigens are O antigen, H antigen, and VI antigen. Is it clear? O, H, and VI. You see that O antigens, they are also called as cell wall antigens or somatic antigens. You can see here in the picture. We'll zoom in this picture. Yeah, O antigen. This O antigen is also known as somatic antigen or cell wall antigen. And then we have the H antigen. The H antigen belongs to the flagellar antigens. You can see in the picture here, the flagellar antigens are the H antigens. Okay, this is H antigen. O is the cell wall antigen. H antigen is the flagellar antigens. They are found in the flagella of the motile bacteria. And then we have the VI antigen. The VI antigens are the capsular antigens, meaning it is located on the surface of the bacterial capsule. It is seen on the capsule, that is cell wall, and this is capsule. VI is the capsule antigen. Okay. VI antigen is located on the capsule, that is the surface of the bacterial capsule. So now you can see the Salmonella typhi survives intracellularly in the tissues of various organs. So we see that this S. typhi, they will invade the host cell, particularly the macrophages, and they stay inside the cells. So they are seen intracellularly, and it is seen in the lot of various organs of the body. It is readily killed by drying. So externally, in an external environment, the typhoid bacteria can readily be killed by drying, by pasteurization, and also by the common disinfectants which are used. They can easily be killed. Now comes the reservoir of infection. The reservoir of infections, man is known as the only reservoir of infection, and he is the reservoir via the cases and the carriers. So we see that he is the reservoir through cases and the carriers. The cases can be a mild case, a missed case, or a very severe case. And then a case is infectious as long as the bacilli is appearing in the stools or in the urine. So we see that the case remains very infectious as long as the bacilli is appearing in the stools or in the urine of the infected individual. Then comes the carriers. In the carriers, we have a convalescent carrier, temporary carrier, and a chronic carrier. To begin with, a convalescent carriers. The convalescent carriers of the typhoid is an individual who has recovered from the typhoid fever, but still he continues to shed the Salmonella typhi bacteria in its feces and occasionally urine for a period after their initial infection. Did you understand what is convalescent carrier? He has recovered from the infection, but still is shedding the bacteria in the feces and occasionally in the urine. Then we have the temporary carriers. A temporary typhoid carrier is an individual who sheds the Salmonella typhi bacteria in the stool or the urine for a period of 3 to 12 months, even after recovering from the typhoid fever. This period of shedding does not extend more than a year. So this distinguishes between the chronic carrier. What are the temporary carriers? They shed the bacteria just for 3 months up to 12 months, but not beyond 1 year. But if the S. typhi is shed beyond 1 year, okay, if the person is excreting the bacilli for more than 1 year after the clinical attack, they are known as chronic carriers. A chronic carrier state may be expected to develop in 2 to 5% of the cases. So in around 2 to 5% of the cases, you can see the chronic carriers development. Is it clear? Convalescent for 3 weeks to 3 months. Temporary from 3 months to less than a year. From 3 months to less than 1 year. Chronic carriers more than 1 year. Simple, right? Convalescent carriers for 3 weeks to 3 months. I hope it is clear. Now we move further to the chronic carrier. Chronic carrier will excrete the bacilli for several years. Maybe it may be as long as 50 years. Either they are shedding the bacilli continuously or they might be shedding it intermittently. That is, they shed for some time, stop it, and then again they start shedding the bacilli. So, chronic carriers can spread the bacilli, shed the bacilli for up to 50 years, either continuously or intermittently. The famous case of the typhoid Mary will give rise to more than 1,300 cases. So, we know that typhoid Mary, who was, infecting a lot of individuals there. She was a very known case of typhoid. She infected more than 1,300 people. The World Health Organization has recognized her. So we see that the case of typhoid Mary, she gave rise to more than 1300 cases in a lifetime. This is a very good example of the chronic carriers. Then we will move further to the source of infection. The primary source of infection are the feces and the urine of cases and carriers. So we are very well aware of the cases as well as the carriers. Convalescent carriers 3 weeks to 3 months, and then temporary carriers 3 months up to 1 year, and chronic carriers more than 1 year. So these people, if they are shedding the bacilli in the feces and the urine, that can be the source of infection. The secondary sources of infection can include the water, food, fingers and flies. Okay. Food, fluid, you can like remember it as fluid or water. Food, fluid, fingers, flies, feces. Okay, these are the 5 F's you can remember. So this is the feces. Now you can see here, let's zoom in. Yeah, from the feces of an infected person, this can get transmitted through the fingers, through the flies, through the fields and fluids, that is water, and when it is ingested by the food, okay, from the soil, the food, from the water, the food, and the flies when they sit on this stools, and then they sit on the same food which we consume, and the unwashed hands and the fingers contaminated with the feces when there is it which is ingested, again can lead to the new host being affected. Next we will move forward to the host factors. To the host factors, we see the age. Typhoid fever may occur at any age. The highest incidence of this case is 5 to 19 years of age group. So we see that in the age group of 5 to 19 years, there is an increased incidence of typhoid fever. In urban slum areas, preschool age children who are less than 5 years show an incidence rate similar to those of school age children. So even the children less than 5 years are also showing the similar incidence as that of school age children, especially in the urban slum areas. After the age of 20 years, the incidence falls probably due to acquisition of immunity from clinical or subclinical infection. So we see that once the patient is after the age of 20 years, the incidence of the typhoid fever is decreased. It is because of the acquiring of immunity from other clinical infections or the subclinical infections. Is it clear? Then we move further to the sex. More cases are reported among the males compared to the females. Okay, age we saw. Let's write the small let's brief it out in small points. So most commonly you have to remember age, school age children, and less than 5 years. So 5 to 19 years school going children, and also less than that, less than 5 years are also showing similar incidence in urban slums. More than 20 years there is immunity from clinical or subclinical cases. Then comes sex. Males are more affected compared to the females. Males are more affected compared to females, but the carrier state it is more in females. So you can remember the typhoid Mary case. So when it comes, she was a carrier, right, who was infecting individuals for many years. So this you can see by remembering the typhoid Mary. Mary was a lady, so females have more incidence of carriers compared to the males, but generally overall when we take the cases, males have predominance. Then comes the immunity. All ages are susceptible to the infection, we know, but everybody is susceptible. Only the incidence rates are higher in cases of children 5 to 19 years of age group. Antibody may be stimulated by the infection or immunization. The serum antibodies are not the primary defense against the infection. So we see that what they're saying here is the antibodies are not the defenses against the infection. It is the immunization which is providing the immunity against the organism. Salmonella typhi being an intracellular organism, cell mediated immunity is playing a major role in combating the infection. So, what you remember here is immunity. Yes, the persons acquires the immunity in cases of typhoid infection, and here the cell mediated immunity plays a major role in combating the infection because the S. typhi is invading the host cells. As I told you earlier, the S. typhi will invade the host cells, particularly the macrophages, and it will start to replicate inside them. This intracellular environment is protecting the bacteria from the host immune responses. Is it clear? What are they saying? Antibody may be stimulated by the infection or immunization in the body. This point is very clear. When does the antibodies come up in the body? Whenever we get the immunization done, the antibodies are coming up, and then whenever the person is infected, so this is artificial immunity, and this one is natural immunity. Whenever the person is infected, the antibodies come up. And then we see that the serum antibodies are not the defenses against the infection. As I told you, it is a intracellular thing. Okay. It is an intracellular infection, so it is invading the host cell. So cell mediated, as it is affecting the host, it is invading inside the host cell. So the cell mediated immunity will play a role, whereas the serum antibodies are not the primary defense. Okay, the primary defense, the serum antibodies are not the primary defense against the infection. The cell mediated immunity is a major role in combating the infection. Then comes the environmental and social factors. Season. Enteric fevers are observed all throughout the year. So, we see that it can affect all age groups. They are susceptible to all age groups. Similarly, the season wise, it is observed in all seasons of the year. But the peak incidence is reported in the July to September. So, the peak incidence is attributed because of the rainy seasons and an increase in the fly population. Okay. Then we see outside this period coincides with the rainy season and an increase in the fly population. Rainy season, increased fly population, incidence of the cases is increasing. Then comes outside the human body, the bacilli is found in the water, in ice, food, milk and soil for the varying periods of time. You can find the bacilli in the milk. You can see the milk here. In the milk, ice, food, milk, ice, and then water, soil for the various periods of time. You can find it in the external environment. Then comes the typhoid bacilli do not multiply in the water. Many of them perish within 48 hours. But some bacilli can survive for 7 days. So when it comes specifically water, the bacilli will perish. Okay, it will perish within 48 hours. Within 2 days, the bacilli will die. But it can survive up to 7 days. They may survive for over a month in ice and ice creams. Okay, when the temperature, if it is 2 degrees to 8 degrees Celsius, the bacilli can survive in ice and ice creams for up to 1 month. In the plain normal water, room temperature water, it will die within 48 hours. They may survive for up to 70 days in the soil, which is irrigated with the sewage under moist winter conditions. So, the moist conditions, rainy seasons, these are all the favorable conditions for the bacilli, and it is surviving up to 70 days in the soil, which is irrigated with the sewage under the moist winter conditions. Next, we see the typhoid bacilli grow rapidly in milk without altering its taste or appearance in any way. So, in the milk also, the bacilli will grow, multiply very easily. It grows fast in the milk. It does not change its appearance and taste. Vegetables which are grown in the sewage forms or washed in the contaminated water are a positive health hazard. We see that when the vegetables are grown in the sewage water or the sewage forms, they are washed in the contaminated waters, they are causing a health hazard. Okay, these factors are compounded by social factors like the pollution of the drinking water supplies, open air defecation. Again, if the bacilli is found in the stools, the flies sitting on the stools can transmit it to the food, and then various others like the soil, water contamination because of the infected stool. So, open defecation is one of the worst things which will cause a positive health hazard in the community. So we see that the factors like the pollution of the drinking water supplies, they are also compounding to increase the infection. The open air defecation, open air urination, low standards of food and personal hygiene, especially in the slum areas, there is a low standard of food, low standards of personal hygiene, and the health ignorance. All of these are contributing to the increase in the infection. Moving further to the incubation period. I hope it is clear. Shall we quickly revise it? So the seasons, tell me which is the season? Now you are supposed to tell me it is rainy season because of the increase in the fly population. Then outside the human body, it can stay in the milk, fly, soil, food, water, etc. Then we will discuss in detail. In the water, normal water up to 7 days. In the ice, it can stay up to 1 month. More than 70 days in the soil which is irrigated with the sewage water. Then in the milk, it stays, multiplies very fast without altering its properties. In the vegetables which are grown in the sewage water or contaminated water, they are causing a threat, followed by the pollution, open air defecation, etc. Then comes the incubation period, usually 10 to 14 days, but it can be as short as 3 days or it can be as long as 3 weeks. It depends upon the dose of the bacilli which is ingested. So if the person is taking less amount of the bacilli is ingested, okay, if the less amount of the bacilli is ingested, it can take up to 3 weeks to develop the infection. Whereas if the amount of bacilli ingested is excessive amount, and then what happens, the person's incubation period can fasten up to 3 days. Okay, so generally on an average, if they ask about the incubation of the typhoid fever, how long does it take for a person to ingest the bacilli, get infected and start developing the signs and symptoms? What is the time period for all of this to occur? Is nothing but the incubation period, which is 10 to 14 days. Okay, half a month. Okay, that is 10 to 14 days. You can remember like that. And then we see the modes of transmission. Typhoid fever is transmitted via the feco-oral route or urine-anal route. Very clear. So far we have told multiple times about it. It is obviously the feco-oral route. The picture demonstration had given you a very clear idea about it. We can see the feco oral route. Okay, the feco oral route, it is transmitted via the 5 F's: fluid, fields, flies, fingers, okay, and food. So now we see here that the typhoid fever is transmitted via the feco-oral route, urine-anal route. This may take place directly through the soiled hands, which are contaminated with the feces or urine of the case or carrier. So if this is a case or a carrier, the feces of an infected person, if he does not wash his hands properly, does not maintain hygiene after passing stools, so there are high chances that the soiled hands or the contaminated hands with the feces and urine of an infected individual, they can be causing the direct infection or the urine of cases or carriers, it can cause the direct infection, or it can also occur indirectly by the ingestion of the contaminated water, by the contaminated milk and the food, as also through the flies it can cause the infection. So you can see the new host, if she eats the food which is contaminated with the flies which were on the infected person's stools, and then they can cause the new infection, and through the fields, through the flies, through the fluid, okay, all of these can transmit the infection. Now you can see this is a picture which is directly taken from your textbooks of preventive and social medicine by Park. You can see the social factors here. The feces and urine from the cases or carriers via the water, or then the water which is used to cook the food can go to the mouths of the well person and infect the individual. And the feces and urine which is found in the soil and the food which is grown in this contaminated soil, again when ingested by the individual, can cause the infection. The flies which are on the resting on the feces and urine of the cases and the carriers, again which when they infect the food, they can cause the infection of the healthy individual. And the fingers which are soiled by the infected individual, when they contaminate the food, then they can cause the infection of various individuals. Then we will move further to the pathophysiology. The pathophysiology of the typhoid fever. When we ingest this contaminated food, what happens? The ingested bacilli will go and invade the small intestinal mucosa. So very easily, calmly, we are supposed to understand. Now there is an infected, contaminated food here. Okay, this is the food. And with this food, when it is ingested, the bacilli will invade the small intestinal mucosa. So the bacilli is invading the small intestinal mucosa. Okay. And then they are taken up by the macrophages and transported to the regional lymph nodes. So there, on reaching, they are taken up by the macrophages, and from the macrophages they are transported to the localized lymphoid tissues over there, okay, to the lymphoid tissue. And this lymph flow will take the bacilli to the regional lymph node. The Salmonella typhi will multiply in the intestinal lymphoid tissue, and they will interact with the enterocytes and M cells. The M cells are seen in the ileal Peyer's patches. This occurs during the 1 to 3 weeks of the incubation period, and the patient presents with the diarrhea. Okay, and then we'll see, we will go in detail. So we see that first what happens, the bacilli is taken up by the macrophages, and then they are entering the lymphoid tissue, and once they invade the lymphoid tissue, they are multiplying inside the lymphoid tissue, and they are interacting with the enterocytes and the M cells. So what are the M cells of the ileal Peyer's patches is? These are the cells of the intestines which are the specialized epithelial cells. They will act as a gateway for the antigens and pathogens from the gut lumen to the underlying immune system. So you can see that this lymphoid tissue is via the help of the M cells. M cells are nothing but a gate which is transporting, or it is presenting the antigen or the pathogen or the bacilli from the gut's lumen to the immune system. And then what happens? All of this occurs during the 1 to 3 weeks of the incubation period. Since the mucosa is being affected here, the patient presents with the diarrhea, and then at the end of incubation period, the bacilli will enter the bloodstream, And then this is the bacteremia phase. When the bacteria enters into the blood, it causes bacteremia, and after the end of incubation period, the bacteremia phase starts. Once the bacilli is entering the bloodstream, the patient starts presenting with the increase in the body temperature, which is the onset of the typhoid fever. And now the bacteria will start invading the other organs via the bloodstream, that is the gallbladder, biliary system, lymphoid tissue of the bowel, and multiply in the high numbers. So they are multiplying inside the gallbladder, in the biliary system, in the lymphatic system. As we saw earlier, it multiplies rapidly in the lymphoid tissue of the bowel, and then they pass into the intestinal tract in the stools. Is it clear? So we know that we will just put it here in the diagram format. First the food is ingested by the person, and then what happens, it enters the mucosa, intestinal mucosa. It is transported to the lymph node. From the intestinal mucosa, it is being transported to the lymph nodes, and they will start multiplying in the lymph nodes. Once they multiply in the lymph node, these antigens via the help of the M cells. We saw that the M cells are nothing but the specialized cells of the malt. You know malt, right? I'll just explain you something here which will help you further. Okay, let me tell you about malt and M cells so that you have a clear clarity about the pathophysiology. So, what is malt? Malt is nothing but mucosa associated lymphoid tissue. That is a diffuse system of lymphoid tissue which is found throughout the body. And this lymphoid tissues will stay in a close contact with the mucosal surface, and they play a very crucial part of the mucosal immune system. And this mucosal immune system is completely different from the systemic immune system. And now here, this mucosal immune system, the malt, mucosa associated lymphoid tissue, which is present throughout the body, they play a key role in defending against the antigens which are encountered at the mucosal sites. So we see that this malt, they stay on the mucous surface whenever the antigens come. Whenever they are encountering with the mucosal sites, they play a very important role in defending against these antigens. Okay. They are found in various organs, like it can be found in the tonsils, this malt, okay, mucosa associated lymphoid tissue throughout the body, right? So you can find it in the tonsils, in the Peyer's patches, and also in the vermiform appendix. Then M cells. These M cells are the specialized cells which are located in the epithelium of the malt. And then what is this function of the M cells? As I told you, they will act as an antennae for the immune system. They will capture those antigens, whatever the foreign body, whether it is typhoid bacillus or any other foreign body, streptococcus, staphylo, any foreign body whichever comes within, they will capture that foreign substances, the antigens from the mucosal lumen, and they will transport across the epithelial layer, and they will go and deliver these antigens to the underlying lymphoid tissues. And once these antigens are transferred to the lymphoid tissue, they will trigger the activation of immune cells, and the immune responses develop against the antigen. Is it clear? Once you have learnt about the malt and M cells, this will give a better clarity now when you go through this. So the bacilli got invaded in the intestinal mucosa. So the malt, intestinal mucosa. Okay, so now the malt got activated here. The mucosal associated lymphoid tissue got activated. The M cells, they took this bacilli, the foreign body, and transferring all through the epithelial layers, they went and gave these antigens to the underlying lymphoid system, okay, lymphoid tissues. And these lymphoid tissue, once the antigen reaches, what this antigen is doing, it has started to multiply even in the intestinal lymphoid tissue. and they are interacting with the M cells which are present in the ileal Peyer's patches. And during this period, since the mucosal membrane is affected, the patient develops with the diarrhea. And now after transversing all this from the lymphoid tissue, it has entered into the bloodstream. Then comes the bacteremia phase, and this bacteria from the it is invading gallbladder, biliary system, lymphoid tissue, and they are multiplying in the high number, and they are passed through the stools. Then you can see here the M cells and the malt. As I told you, the malt cells, these are the M cells which are present on the mucous membrane. You can see the M cell here. Is it clear in the picture given? This is the M cell, and this is the bacteria which is transversing through the epithelial membrane, and it is presented to the lymphoid tissue which is present deep inside the lymphoid system. Under the mucosa, underlying mucosa, there is a lymphoid tissue present. Okay, and you can see the M cells here, lymphatic system. Okay, now we move further to the clinical features. In the stage 1, in the first week, there is a slow rising step ladder fashion pattern of the fever for 4 to 5 days. You can see step ladder fashion of the temperature, slow rising. Okay, first day step ladder pattern it is. Okay, step ladder, first day the temperature can be 97, okay, 98, next day 99, the next day 100. So there is a step ladder. You can see there is a step ladder pattern, step ladder fashion of the increase in the temperature for up to 4 to 5 days, and it is a slow rising. And the patient can also present with abdominal pain and myalgia. Abdominal pain, it can be frequently associated with the diarrhea or constipation. Then the patient will also present with other constitutional symptoms like headache, malaise, and we have constipation. Why have constipation been mentioned here? We saw that the abdominal pain, and then comes constipation. Why constipation? The inflammation is leading to the narrowing of the bowel lumen. You can see the bowel lumen is getting narrowed because of the inflammation. So all of these is inflammation. Okay, here. So because of the inflammation, the lumen is getting narrowed down. It is slowing down the passage of the stool, which is causing the constipation. Additionally, you can see the fever itself and the associated symptoms like the dehydration or the decreased appetite in the person, they also contribute to the constipation. Okay, and then we see there is a relative bradycardia. So the patient will also present with relative bradycardia. What is bradycardia? A relative bradycardia. This sign is describing a situation where the patient with the fever will have a heart rate which is unusually slow for the degree of the fever. Generally, what happens in fever? The patient presents with tachycardia, increased heart rate when the temperature rises. But here, compared to the increase in the temperature, the unusual slowing of the heart rate is seen compared to the degree of the fever. The exact reason is not fully understood, but most probably you can attribute it to the release of inflammatory cytokines and the direct effects of the pathogen on the heart, or because of the electrolyte imbalances as well, as there is dehydration and diarrhea. All of these can also lead to the electrolyte imbalances. All of these can lead to relative bradycardia. Direct action on the heart can also occur because it is entering the organs, various organs, multiplying there and causing a damage. Here you can see now in the first week, what are the things we remember in the first week? Slow rising step ladder pattern of the fever. Okay, and then we see that there is abdominal pain and myalgia, malaise, headache, constipation, and relative bradycardia. Okay, is it clear? Malaise, headache, constipation, relative bradycardia. This is in the first week. Then we move to the stage 2 in the second week. The signs and symptoms of the first week will keep progressing. So the constipation gets more progressed, headache increases, malaise, abdominal pain increases, and there is more relative bradycardia, and the temperature slightly increases. Then what happens at the end of the second week? In the end of the second week, the brain involvement occurs. Okay, that is the delirium, complications. Then coma and death can also occur if it is untreated. I'm so sorry. We have to also study about the end of first week. Let's not go to stage 2. First, let's complete stage 1, end of first week, and then go to stage 2. In the end of first week, the rose spots may appear on the upper abdomen and on the back of the spars. So we see that the rose spots are seen here. Now let me just show you a picture of the rose spots. Here you can see the rose spots are nothing but the slightly raised red spots, rose red spots. They fade on pressure. It is usually visible only on the white skin. Okay, generally if the skin is a little darker, you cannot clearly visualize these red spots, rose red spots. They are slightly raised, they fade on pressure, and they are known as the rose red spots. They are seen at the end of the first week. Okay, so you can see in the clinical feature very clearly, you can see the patient comes with a fever which is lasting for more than 3 to 4 weeks. He can also come up with constipation in the first week or diarrhea in the later on weeks, and then he will also present with the relative bradycardia, the rose red spots in the first week, and then at the end of the first week he can also present with other symptoms like headache, malaise, abdominal pain, etc. Then we see that the patient also presents with cough, splenomegaly, abdominal distension with tenderness, and diarrhea. So let us go slow. So the person presents with splenomegaly. So why does splenomegaly occur? The spleen also plays a very crucial part in our immune system, right? It is actively involved in fighting off all the infections. So what happens in typhoid fever? The spleen will start to filter the S. typhi from the bloodstream, and also it tries to destroy them. Also, when the Salmonella typhi enters the spleen, these macrophages phagocytoses the bacteria, and this will lead to inflammation and swelling of the spleen. So the spleen is actively involved. It is causing a lot of phagocytosis. It is trying to eat up all the bacteria. It is the macrophages are trying to kill them, engulf them. So this is leading to inflammation and swelling of the spleen. And then the patient presents with abdominal distension. First week we have constipation. So you can see in the stage 1, first week constipation. At the end of first week, the patient presents with diarrhea. So I'll explain you. I have clearly told why constipation occurs. Now let's see why diarrhea. Before that, abdominal distension. The typhoid bacteria, that is Salmonella typhi, first it is primarily infecting the small intestine. Once it infects the small intestine, there it is causing the inflammation, swelling of the intestinal walls, and all of these inflammation, the swelling of the small intestine, it is causing the buildup of the fluid. So whenever there is inflammation, there is seeping of the fluid from the bloodstream, from the vascular system into the interstitial system. So the fluid from the blood vessels is seeping into the cells there. So the inflammation is leading to the buildup of the fluid and gas within the intestinal lumen, and because of the fluid which is seen in the intestinal lumen, this is resulting in the abdominal distension. And now we know the hepatosplenomegaly is also seen here. The liver, spleen, they are involved in the response to the typhoid infection. They are getting enlarged. All of these are also contributing to the abdominal distension, and the tenderness, especially the tenderness, is seen in the right upper quadrant. Constipation also occurs because of the inflammation and the decreased bowel motility, and they can also contribute to the abdominal distension and the tenderness. Is it clear? Then we see the diarrhea. Why diarrhea occurs? Again, we know that small intestine is Salmonella typhi is affecting the small intestines, and it is invading the intestinal cells. So this invasion is triggering the MALT, mucosal associated lymphoid tissue, and that will go and the M cells are taking up the antigens and going and presenting to the lymphoid tissues. So this invasion is triggering an inflammatory response. This inflammation will cause the intestinal cells to swell up. They start becoming leaky, leading to the fluid and electrolyte loss in the intestinal lumen. Okay, CFTR channels open up, and then we have the leaking up of the fluid, leading to the fluid and electrolyte imbalances. And then comes the reduced absorption. Since this inflammation, all of it is occurring in the small intestine, it is reducing the ability of the intestinal cells to absorb the nutrients and the fluid. So what happens now? No more the intestine is able to absorb the nutrients very beautifully like it did before, because of the lot of inflammation which has occurred in this intestines, and all of this is contributing to the diarrhea. And then comes again the combination of this fluid loss or the impaired absorption and increased intestinal motility. All of this is attributing to the loose watery stools which are associated with the typhoid fever. Is it clear? I hope it is clear. In the stage 1, you remember very nice. Stage 1, what did we see? We have fever, we have bradycardia, constipation, the main symptoms, and then headache, malaise, myalgia, etc. And then comes the end of the first stage. In the end of the first week, what happens? Row spots. We have row spots, cough, splenomegaly, abdominal distension, tenderness, and diarrhea. Then we'll see the stage 2. In the second week, signs and symptoms of whatever the first week we went through will increase or progress. Lastly, in the end of the stage 2, that is end of the second week. What happens in the second week, end of the second week? The patient will start with symptoms like delirium, complications, coma, and death. Is it clear? So we know that now there is involvement of organs. The bacteria via the bloodstream, it is circulating and it is affecting the various organs including the brain. So here including the brain is affected, leading to coma, delirium, and then we have headache as well, right? Yeah. Now we move further to the stage 3, third week. The febrile become toxic and anorexic. Significant weight loss is seen in third week because there's lot of diarrhea, malnutrition, malabsorption, and then loss of fluid, nutrients. So all of this is leading to the weight loss. Typhoid state, where the patient is going into apathy, confusion, and psychosis. High risk, 5 to 10% of hemorrhage and perforation can cause death. So the intestinal perforations can occur. All of these can lead to hemorrhages and perforation that can result in death. Then we have stage 4, the fourth week. Is it clear? The third week, what is happening? There can be perforations of the intestines, hemorrhages, then apathy, state of complete, loss of feelings or emotions towards the external environment or people. There is apathy, state of apathy, confusion, and psychotic state. And there is also weight loss, anorexic. Patients stop taking food or fluid. Then what happens? Stage 4, recovery period. If the individual survives this fourth week, the fever, mental state, abdominal distension will start to slowly improve over a few days. Once he has gone through all this, survived through it, then what happens? The fever comes down, mental state becomes stabilized, abdominal distension improves. Intestinal and neurological complications may still occur in surviving untreated individuals. So we see that neurological complications, intestinal complications, they can still occur even if the person in surviving untreated individuals. Weight loss, weakness, will last for months together. Okay, once the patient has gone through this typhoid fever, weight loss and a very debilitating weakness is seen in these patients. Some survivors will become asymptomatic STIV carriers, and they have the potential to transmit the bacteria indefinitely. So we see that the person can become asymptomatic. No more there is fever, bradycardia, constipation, diarrhea, abdominal distension, coma, delirium, headache. All of this will go down. Yet the person can shed the bacilli in the stools and the urine for up to 50 years. So he can be a potential transmitter of the bacteria for an indefinite period. Now you see the typhoid fever symptoms summarized in this slide. The patient can present with headache, abdominal pain, nausea, vomiting, GI symptoms. Okay, then myalgia, muscle pain, loss of appetite, anorexic state, tiredness, weakness, irregular fever can be there. Okay. Then comes the diagnosis and investigations. Let us start with the blood culture. The specific serological test. Okay, under the blood cultures, we have the specific serological tests. To identify the salmonella antibodies or antigens, the fluorescent antibody study is taken up to look for the substances that are specific to typhoid bacteria. So let me explain the fluorescent VI antibody test. This is a serological test. You can see it is a serological test. This VI antibody test, let me write down what you have to remember. Fluorescent. You have to remember fluorescent VI antibody test. Okay, this is what you have to write it in your examination papers. If they ask the investigations included in your question, you know very well the clinical feature. Now if I just question you, let's go back. I question you, what is the causative factor? STIV. Then I will ask you, what is the problem statement? What is the age factor? Then the environmental factor and the agent factor. What is the mode of transmission? And then we have the clinical features, which we explained in detail, and you're very well aware about it. And now I am going to the investigations. So far I hope everything is clear. If you have any doubts, feel free to put it down in the comment section. I hope I will be able to clear it out to you, and then we will move further to the investigations now. What happens? The VI fluorescent antibody test is carried out in cases of the typhoid fever. This is used to diagnose the typhoid fever, and this test is also used to screen the carriers of the typhoid fever. What happens? This fluorescent antibody test will detect the presence of antibodies against the VI antigen of Salmonella typhi. So the capsular antigen is the VI antigen, right? Though O antigen stands for the cell wall, H antigen stands for the flagella, and VI antigen for the capsule, which is found on the surface, capsular antigen. So when we look for this test, we see whether the antibodies have been developed in the body against the antigen of Salmonella typhi. The test is involving reacting a patient's serum with the antigen of the Salmonella typhi bacteria. If the antibodies are against the VI antigen are present in the patient's serum, they will bind to the antigen. So the presence of these antibodies is then visualized using a fluorescently labeled anti-human antibody. So let me draw it in a, let me make a slide for you. Yeah. So what happens? We took the serum of this individual. Okay. Now we are going to check, what is our main objective? We are going to check if antibodies are present or not. Now to check if the antibodies are present or not, we are going to make a interaction with the patient's serum and the antigen. We have this VI antigen present. Okay. And when the patient's serum is made to interact with it, we are checking if the antibodies are binding to this antigen or not. If the antibodies are present, they will bind. So it concludes it is positive. If the antibodies have not developed and not binding to this antigen, then we declare it as a negative test. Okay. Is it clear? Now, how do we visualize these antibodies? Using a fluorescently labeled anti-human antibody. Then we move forward to the serological test for the typhoid fever. We have other tests like Vidal test and ELISA. Now let me first explain Vidal followed by ELISA. So we see that Vidal test is also detecting the antibodies which are produced by the body in response to the Salmonella typhi infection. Here in Vidal test also you are detecting the antibodies. These tests will help us to diagnose the typhoid fever by identifying the presence of antibodies in the patient's blood sample. Key aspects of serological test for typhoid fever are the Vidal test. So this test is using a suspension of the killed Salmonella typhi bacteria to detect whether the antibodies are present in the body against the bacteria, or if the antibodies are present in the serum against the bacteria. The other serological test, we have enzyme linked immunosorbent assay, which and a rapid diagnostic test like TYPHOID. Okay, TYPHOID, they can also be used for serological diagnosis of typhoid fever. So basically in all these serological tests, we are taking the serum of the patient, making it to interact with the killed bacteria or the killed antigen bacilli, and then this killed bacteria will interact with the antibodies which are present in the serum. If it is positive, if it is not, it won't interact. Is it clear? We are checking if antibodies are present in the serum or not. Then we will go to the urine and stool culture, which can be performed in the second and third week. Okay, the urine and stool culture. The stools culture can be used to identify the S. typhi in the fecal samples. So we collect the fecal sample and we will use it to identify the S. typhi. However, the sensitivity is comparatively low. Okay, compared to the blood culture, stool cultures are comparatively low sensitivity, and they may not always be positive during the first week of illness. We need to wait to do the stool culture for the second and third week. They don't show positive results in the first week of illness. And the urine cultures can also be used to detect the S. typhi, and we see their sensitivity is also generally lower than that of the stool cultures. Then we see the marrow culture. Marrow culture is, you can see here what's written, 90% sensitive unless until after 5 days commencement of antibiotic. So let me explain you this point. Marrow culture. Bone marrow culture is a sensitive diagnostic test again for the typhoid fever here. It is often yielding more positive results compared to the blood culture. Okay, 90% sensitive. After 5 days commencement of antibiotics in the body, it is 90% sensitive. Okay, what happens here? A small blood sample of the bone, a small sample of bone marrow, not the blood sample, sorry, a small sample of the bone marrow is obtained. Typically it is taken from the hip bone, okay, from the iliac crest. We take a small sample of the bone marrow, and this marrow will be aspirated, and then this marrow aspirate, now it will be cultured in an environment where the bacteria like S. typhi can grow. And once the suitable environment where the bacteria can be grown, the marrow is aspirated, the aspirated marrow is cultured. And once all of this is done, we do the microscopic examination. So what did we do? We took the marrow, cultured it in an environment where the bacteria can grow, and we are examining it under a microscope to identify whether there is a presence of bacteria or not. Okay, and then we have punch biopsy samples of rose spots culture. So we saw that rose spots are the slightly raised rose red spots which will fade away from pressure, is what we studied under the clinical feature. And now we are taking a small sample of the skin tissue. They are slightly raised. We are taking a small sample of the skin tissue from a rose spot, and then the sample is then cultured in the lab to see if there is a growth of Salmonella typhi bacteria. Okay, punch biopsy samples, and this is 63% sensitive. Then comes the clot culture. The clot culture is again a modification of the blood culture, where the blood sample is allowed to clot before inoculation into a broth medium. So we are taking the blood sample, allowing it to clot, and then we are inoculating it into the broth medium. Why are we doing this? This technique is aiming to enhance the bacterial growth and isolation. So we are enhancing the bacterial growth and its isolation, especially for the bacteria which may be inhibited into a whole blood culture. Okay, when we are doing it in a whole blood culture, if the bacteria are not growing properly, we are not able to understand it, then we will try to coagulate the blood. There is a blood culture where the sample is clotted, and then we are trying to enhance the bacterial growth and identifying. Is it clear? The cultures can also be obtained from CSF, peritoneal fluid, mesenteric elens, and resected intestines, gallbladders, pharynx, tonsils, abscess, bone, etc. Moving further to the serology Vidal test. So let us discuss Vidal test in detail here. Very important. Vidal test to help diagnose the typhoid fever and also to diagnose the paratyphoid fever by detecting the antibodies in the blood. So we need to detect the antibodies in the blood. What is the mechanism? The test relies on the principle of agglutination, where the antibodies in the patient's serum will bind to and cause the clumping of the bacterial antigens. So you can see here the tube agglutination test. It is a tube agglutination test. It is detecting the antibodies, O antibody, H antibody. It is used to diagnose the typhoid fever and paratyphoid fever, and we are also testing for H agglutinins in Dreyer's tube, a narrow tube floccules at the bottom. So let me explain you this. So we see that what are we doing? It is okay. Let me tell you what is the principle of this test. The principle of this test is agglutination. Okay, the principle of this test is agglutination. If the antibodies which are present in the patient's serum, they are going to bind with the bacteria and cause the agglutination. Okay, antibodies in the patient's serum will bind with the bacteria and then cause the clumping. So the Vidal test will detect antibodies against two main antigens. What are the two main antigens? O antigen and H antigen. O antigen, we see that O antigen is found on the surface of the Salmonella typhi, paratyphi, and H antigen is found in the flagella. The H antigen, we see that they are specifically directed against the flagellar antigen, okay, of the Salmonella bacteria. And then we see that it is done in Dreyer's tube, a narrow tube. Floccules are seen at the bottom. So you see that the H agglutinin, whatever the agglutination has occurred, the H agglutinin, it is attributing to the H antigen and it is directed against the H antigen. Here what happens? Narrow floccules. So these antigens will form the agglutination by clumping together. They will form the visible floccules or small clumps in the test tube. What do you mean by narrow floccules? If the floccules are narrow, it suggests that there is a lower concentration or a weak interaction between the antibody and antigen. This indicates there is a low titer of H agglutinins or a very less severe infection. Are you understanding it? Is it clear? If the narrow floccules are seen in the tubes, if the narrow floccules are seen, it shows that the infection is less severe. Okay, lower concentration or a weaker interaction, low titer of H infection or H agglutination or less severe infection. In the older Vidal tube test, a chalky or matty appearance is seen at the bottom of the tube, which is indicating a positive reaction of O agglutinin. Okay, here we see that the patient's serum is containing the antibodies which are reacting with O antigen in the picture. You can see testing for O agglutinins is done in the Felix tubes. For H antigen, it is done in the Dreyer's tube. Okay, and if the narrow floccules are seen, low concentration. And then for the O antigens, the test tube uses Felix tubes. In the Felix tubes, the chalky matte appearance is seen at the bottom. If it is seen at the bottom, it indicates that there is a positive reaction of O agglutinin. O antigens, O antibodies are present in the serum of the individual. Then we will move further. They are intubated at 37 degrees Celsius overnight. Is it clear? Next, we will move further to the typhoid complications. So, what are the various complications you see? The typhoid intestinal perforation. So, intestinal perforations occur because the bacteria is causing the ulcers in the intestinal wall, which is creating a hole or the perforation, and these perforations can further lead to peritonitis and a very life-threatening abdominal infection, and it can also lead to gastrointestinal hemorrhages, the severe ulcerations or the severe inflammation. They will cause the internal bleeding, and the bleeding can be so severe that the patient can also require a blood transfusion or immediate surgery to stop the bleeding, and it can lead to peritonitis. Peritonitis is nothing but the inflammation of the inflammation of the abdominal cavity. The infection of the abdominal cavity can occur by the intestinal perforation. Okay, and then we have hepatitis, the inflammation of liver. We have myocarditis, inflammation of the heart muscles. We know we are the bloodstream. The bacteria will be filtered out by the spleen, leading to splenomegaly. It can affect the liver, leading to hepatitis. Then we have, it can directly affect the heart via the bloodstream, leading to myocarditis and encephalopathy. Okay, cross through the bloodstream, and it can affect the brain, causing brain inflammation, which leads to confusion, delirium, seizures, etc. Okay, then it can also lead to septicemia, shock. We have encephalopathy, pneumonia, anemia. So we see that how it leads to encephalopathy is the bacteria will cause the brain inflammation, leading to encephalopathy, which is confusion, delirium, seizures. And then we also see by spreading to the bloodstream, once the salmonella typhi will multiply in the Peyer's patches, ileal Peyer's patches, and the intestinal ulcers, it can break through and spread into the bloodstream, and that can also lead to septicemia. Is it clear? Now we have categorized the complications. In the bubble, it can lead to perforation and hemorrhage. The septicemia foci in one spot in the it can lead to bone and joint infection. Septicemia can occur, it spreads into the bloodstream. In the brain, meningitis. In the gallbladder, cholecystitis. And then we have the toxic phenomenon, where it can affect the kidneys, causing nephritis. It can affect the heart, causing myocarditis. And the chronic carrier stage can cause a persistent gallbladder carriage. Is it clear? And here we saw the intestinal perforation, GI hemorrhages, hepatitis, cholecystitis. We have cholecystitis, myocarditis, shock, encephalopathy, pneumonia, affect the lungs, leading to pneumonia, anemia, and then hepatitis, etc. I hope the complications are clear. Moving further to the control of the typhoid. The control or elimination of the typhoid fever is well within the scope of modern public health. Okay, the scope is seen within the modern public health. This is accomplished facts in many developed countries, because it is already accomplished in the many developed countries. There are generally three lines of defense against the typhoid fever. One, we need to control the reservoir. Then we have to control the control of the sanitation, and thirdly, immunization. Is it clear? Control of reservoir cases. Okay, in the cases, how can we control? By early diagnosis. This is of a vital importance. Okay, early diagnosis is very important, where we are diagnosing the symptoms in an early stage. Then we can perform the culture of the blood and stools, which are also an important investigation in the diagnosis of the cases. And then comes notification. Notification, this should be done where such notification is mandatory. So once we diagnose the case, we need to notify the case. The notification is supposed to make it a mandatory. And then comes isolation. Since typhoid fever is very infectious and the patient keeps shedding the bacilli, so we have to try to isolate the cases. And since the typhoid fever is infectious and has a prolonged course, the cases are better to be transferred to the hospitals and a proper treatment has to be given. As well as try to prevent the spread of infection even in the hospitals. As a rule, the cases should be isolated till the three bacteriologically negative stool and urine reports are obtained. Okay, on 3 separate days we need to isolate the patient till we obtain bacteriologically negative stool reports for 3 separate days. Then comes the treatment part. The fluoroquinolones, they are the widely regarded as a drug of choice for the treatment of typhoid fever. They are relatively inexpensive, well tolerated. They are more rapidly and effective than the former first line drugs. The former first line drugs were ampicillin, amoxicillin, and then that is cephalosporins. Okay, beta lactams were used. So we have first initially the chloramphenicol, ampicillin, amoxicillin, trimethorphan, sulfametazolol was used. Now they are using the fluoroquinolones. Okay. Then we move further to the disinfection. Stool and urine are the sole sources of the infection. So they should be received in a closed containers and they have to be disinfected with the 5% cresol for at least 2 hours. Okay, they have to be disinfected by cresol for at least 2 hours. All the soiled clothes, all the soiled linen should be soaked in a solution of 2% chlorine and the steam sterilized. Okay, the linen should be steam sterilized. These are all these sanitary measures have to be followed by the hospitals. The soiled clothes of the infected individual has to be soaked in the solution of 2% chlorine. They have to be steam sterilized. Nurses and doctors should not forget to disinfect their hand. Follow up examination. Now we are going up to the follow up. Follow up examination of the stool and the urine should be done for the S typhi 3 to 4 months after the discharge of the patient. Again, the stool culture, urine culture after 3 to 4 months of discharge of the patient, and again it has to be done at 12 months to prevent the development of the carrier state. Okay. Follow up urine culture, stool culture 3 months post discharge, and again at 12 months post discharge, the stool and urine culture is performed to prevent the carrier state. Okay, then we will move further to the carriers. What we can do in cases of carriers? Is it clear? How can we control the typhoid? By early diagnosing the symptoms, notifying the case, isolating the patient, providing the treatment. Fluoroquinolones is a drug of choice. Disinfecting 2% chlorine, the linen has to be done, and in the cresol we have to that is 2% chlorine, and steam sterilization is for the clothes, and then 5% cresol disinfection is done for the stools. Okay, the containers has to be disinfected with the stool whatever and urine containers whatever they are collected, they have to be closed and they have to be disinfected with 5% cresol for 2 hours. Is it clear? Now we will move further to the carrier state. In the carriers, how can we control? uh, identifying the case, and then comes the treatment part. Identification has to be done, and then we have by the again identification can be done to the stool cultures, urine cultures, and then we have the treatment part. The carrier should be given an intensive course of ampicillin or amoxicillin 4 to 6 grams a day. Together it is given with probenecid, extended spectrum of penicillins. So we have ampicillin, or amoxicillin. It is combined with the extended spectrum of penicillin. When these two are not effective, we combine this drug with probenecid. Okay, probenecid. That is 2 grams per day for 6 weeks. Okay, this course has to be given to the carriers. Then comes surgery, cholecystectomy. Why cholecystectomy? Cholecystectomy with the concomitant ampicillin therapy is regarded as a successful approach for the treatment of carriers. Okay, the concomitant ampicillin therapy plus cholecystectomy is the most successful approach which they have seen in cases of controlling the carriers. Since the gallbladder is a reservoir of the bacilli, we are opting for the cholecystectomy. Then the cure rate may be as high as 80%. Urinary carriers are also easy to treat, but the refractory cases may need nephrectomy, where one kidney is damaged and the other healthy. Okay. Then we see that we have surveillance. The carrier should also be kept under surveillance. They should be prevented from handling the food, milk or water for others. And the carriers, you can see here, let me add on the points. Identification, treatment, surgery, and we also have surveillance. They have to kept under surveillance, fourth point. And you also need to educate, okay, the health education regarding the washing of hands with soap after defecation, after urination, and we also prepare the food. Before preparing the food, they need to wash the hands. And then in short, the management of the carriers is continuing to be a very unsolved problem because it requires a lot of effort. And then comes the control of sanitation, protection and purification of the drinking water supplies, improvement in the basic sanitation, and the promotion of the food hygiene are the essential measures to interrupt the transmission of typhoid fever. How do we remember it? Food and water. Okay, food. Promotion of food hygiene. Water. What is water? Purification of the drinking water. Then basic sanitation has to be maintained. So these are the essential measures which are taken to interrupt the transmission of typhoid fever. So we see, for instance, typhoid fever is never a major problem where there is a clean domestic water supply. So even in the developed countries, they have combat all this, the transmission of the typhoid fever. To prevent it, there is clean domestic water supply necessary, and the sanitary measures are not followed by health education will only produce temporary result. So the patient has to maintain the sanitation. However, when sanitation is combined with the health education, the effect is cumulative. It is leading to the steady reduction of the typhoid morbidities. Then we will move further. A complementary approach to the prevention is the immunization, which is the only specific preventive measure which is leading to the highest benefit for the money spent. Okay, immunization against the typhoid does not give 100% protection, but it definitely lowers the incidence and the seriousness of the infection. We see that it is the most effective complementary approach. 100% protection, okay, might not be given. Yeah, not exact 100% protection might not be given, but you can see that the seriousness of the infection both the incidence as well as the seriousness, I mean the severity of the infection is lowered. It can be given at any age up to 2 years. It is recommended to the those who are living in the endemic areas, to the household contacts of those infected individual, or the groups at risk of infection like the school age children, hospital staff. They are at a high risk of contracting with this infection. And the travelers who are proceeding to the endemic areas, they can be immunized against the typhoid fever. And those who are attending yatras, melas, they can also be immunized. Now we see that the vaccines which are given here, TY21A, okay, typhoid 21A, typhoid vaccine, typhoid 21A, okay, a vaccine is a vivotif, okay, vivotif. Vivotif is nothing but an oral typhoid vaccine. Typhi 21A vivotif. It is an oral typhoid vaccine. It is produced by Berna, Swiss. Okay, this oral typhoid vaccine is produced by Berna Biotechnology, Bern, Switzerland. Okay, he belongs to Berna Biotech, Switzerland. And then we see that is the Serum and Vaccine Institute. Okay, belonging to the Serum and Vaccine Institute. How it is given? There is oral administration. The vaccine is taken orally. Typically, one capsule is taken. In the capsule form, one capsule is taken by the mouth. And then the number of doses which are necessary are 4. The time between the doses is 2 days. Okay. Number of doses are 4 doses are taken, and between those 4 doses, the time gap given is 2 days. Okay. On day 1, you're taking the dose, giving a gap of 2 days, followed by another dose, gap of 2 days, followed by another dose, and so on. Then the total time needed to set aside for vaccination is totally 2 weeks. It can go up to 2 weeks. The minimum age for vaccination is 6 years. You see, the vaccine is suitable for the individuals 6 years of age and older, but it is not recommended for those who are having a weakened immune systems. Booster dose is given, needed or recommended every 5 years. Is it clear? The typhoid 21A is a vivotif Berna Swiss Serum and Vaccine Institute. It is from the Berna Biotech Bern Serum and Swiss Institute. Berna Swiss Serum and Vaccine Institute. How is it given? Orally in the form of capsule. Doses are 4. Then the time between doses gap is 2 days. Total number of days which have to be kept for vaccination is 2 weeks. Minimum age, it is suitable for children 6 years and above. Not recommended for those who are having a weakened immune system. And booster doses given every 5 years. Then we see the Typhium VI. Typhium VI, also known as VI capsular polysaccharide vaccine. We see VI CPS, Typhium VI antigen, or vaccine, Typhium VI vaccine, that is VI CPS. What is VI CPS stands for? C stands for capsular. We know that VI antigen is a capsular antigen. From there you can relate VI capsular polysaccharide vaccine. It is an injectable vaccine for preventing the typhoid fever, a serious bacterial illness which is caused by the Salmonella typhi. So this Typhium VI is a typhoid fever vaccine. It is a vaccine, injectable vaccine, which was produced by Pasteur. Okay, it was produced by Pasteur. It is an injection. The number of doses is 1, which is 0.5 ml. IM injection is given once 2 weeks prior to the expected exposure. Is it clear? Total time needed to set aside for vaccination is 2 weeks. So 2 weeks prior to the expected exposure, we are giving the injection. For example, if the person is going to travel to the endemic areas, 2 weeks prior to the expected exposure, we are giving this injection. A booster dose, minimum age for vaccination is 2 years. Okay, a booster dose 0.5 ml IM 2 years under conditions of repeated or continuous exposure to the S. typhi organism is recommended. So booster dose is given 2 years if the patient is under the conditions of repeated exposure or a continuous exposure, then S. typhi organism he is exposed to. So we are recommending the VI CPS typhium VI, which is discovered by Pasteur. This injection typhium VI vaccine is recommended for the individuals for 2 years. And then the age group minimum, it is approved for 2 years of age or older children. Is it clear? A little tricky, but since we have understood in detail, easy to remember. The names TY, what are the names? Yeah, the names you have to remember. TY, okay, there's something wrong. Yeah, the names are TY21. Let me write it down here only. TY. I'll summarize it to you in a plain sheet so that you can also recall it. Okay. Yeah. So what are the two vaccines which are given here? The two vaccines are, the first vaccine is TY21A typhoid vaccine. This was known as VivoTIF. The other name of this is VivoTIF. Is it clear? TY21A, also known as VivoTIF. It is who produced this vaccine? It was produced by Berna Biotech from Bern, Switzerland. Okay, Berna. Then we see the mode of administration. It is given orally. What is the form? It is in a capsule form. How many capsules are given? 4 capsules. 4 capsules are given. Total 4 doses. Number of doses 4 capsules. Okay. What is the gap between the capsules? The doses is 2 days. The gap is 2 days. How many weeks you have to spare for the total vaccination? 2 weeks. And what age group does it belong to, suited for? 6 years or older. Booster dose is given for at this gap of 5 years. Okay. Recommended every 5 years we give the booster dose. Now we will revise typhium VI antigen. Typhium VI. So what happens in the typhium VI? Yeah. In the typhium VI, it is a typhoid fever vaccine. Who produced this vaccine? It is produced by Pasteur. It was produced by Pasteur. It is in the form of injection. How much? 0.5 ml. How is it administered? Intramuscularly. 0.5 ml injection. And once in 2 weeks prior to the 2 weeks, the time spared is 2 weeks prior to the exposure. Okay. And then booster dose again 2 years if there is a continuous repeated exposure. The age group 2 years and above. 2. Okay. Is it clear? Now when you see here, 1 dose is given. The time total time 2 weeks. Minimum age 2 years. Booster dose again 2 years. Is it clear? So with this we come to an end of the session typhoid fever. I hope you enjoyed the video and the concept is clear. If you have any doubts, feel free to put them down in the comment section. And if you like the video, don't forget to hit the like button and subscribe.